So the next topic we were going to talk about was, before we get into the treatment data, thinking about when we're meeting a patient, what do we think is going to happen to them? Are they someone, whether it's with localized disease, locally advanced disease, new hormone-sensitive metastatic disease, is that someone who we're really worried about, or someone we think might get years of disease control with androgen deprivation therapy? And what are the factors that you all look at when you meet a patient, look at their pathologic data, their radiographic data, their laboratory data, to help you prognosticate how they're going to do?
So usually in a community settings, I tend to, if patient has a prostate biopsy, definitely I look at Gleason score, Gleason 8. If there is a MRI or a imaging suggests T3, T4 lesion, seminal vesicle invasion, then definitely I look at the PSA volume and the velocity. If PSA is high, as by high risk criteria by NCCN, above 20, then it certainly our threshold goes higher, that using, apart from androgen deprivation, to use AR agonist right away for sure, because we know this patient. And then I think following the velocity, now patient got surgery, then we definitely look at, is it early recurrence? If post prostatectomy, PSA never became undetectable, and now they are, velocity is higher, than those patients, we know that we are going to be in challenge. That's how, at least I make the decision. What are the other factors you've been using?
Yeah, I agree with you, Dr. Mehta. We're using the same things, grade group 4, grade group 5, taking a look at the biopsies, taking a look at the percentage of the cores that are involved, high percentage of the cores, how many cores are involved, taking a look at the pathology, intraductal, cribiform pattern being present, but otherwise those same things with regards to looking at very high risk or high risk per our NCCN guidelines.
Do you all look at either next generation sequencing of genomic or tumor DNA, or any of the gene expression panels?
So we've been participating the NRG GU9 and 10 trial for Decipher, based genomic assays. So all the patients we've been trying to put them through intermediate risk, especially if they choose the radiation arm. And at this point, I tell the patient, maybe this genomic assay will tell us, are we a good risk or more a personalized way? Are we the way I present the patient is more, is it a bad cancer or an ugly cancer? And if it's a bad cancer, we tend to do the standard of care, but ugly one, that's where we want to reach out and use from our armor and use the medicines.
In terms of what I do, I try always to get the genomic data for patients with new metastatic disease, and for the localized or newly recurrent after prostatectomy, if they have a detectable PSA after their surgery, and Gleason 9, and they're in their 50s, those are the people where I may send it, even though it may not change their management right now. I find it prognostically valuable to see, do they have loss of 2 out of 3 of the bad tumor suppressors, P53, RBP10? Do they have an SPOP mutation, which may project excellent response to androgen deprivation? Do they have microsatellite instability, where down the road they're going to be the people who respond really well to immune checkpoint inhibitor, BRCA mutation, et cetera? So I don't need it immediately for the highest localized or the biochemical recurrence patients, but I sort of like to have that data in my pocket.
And are you using tissue-based or liquid-based, or whichever is the easiest?
I always do whatever's the easiest in life. I think if it's pretty recent, I'll use the tumor, especially if they've had a prostatectomy recently or prostate biopsies. If it's been years, I'll either try to get a fresh biopsy, which I haven't been that aggressive about, or use the liquid, I think, more and more.
Yeah, I agree. Sometimes, just practically speaking, you don't have the NGS test results back by the time that you feel you need to make a treatment decision. But in the rare cases where I did have that information and they had, RB1 or P10 or something like that, it probably did push me towards more aggressive therapy, maybe doing triplet therapy instead of just ARSI and ADT. And then again, this doesn't help with your initial choice of therapy. But I also use PSA response at 28 weeks because there were a couple SWOG trials that showed at 28 weeks after starting treatment, if you had a PSA of, I believe, greater than 4, 2 to 4,
0.2 to 4. 0.2 to 4.
0.2 to 4, sorry, or less than 0.2, that was very prognostic of overall survival. And there's been a couple patients who've had a simultaneous malignancy, like maybe what looks like a localized renal cell carcinoma, and we're wondering, do we need to do anything about that? And I've used the PSA response at 28 weeks to give me an overall sense of how that patient might do. And if they have a longer projected overall survival, then we might consider taking that out with surgery.
Yeah, and I'll just add that in addition to whatever has already been said, I agree with tissue NGS. I've also been trying as much as possible to send germline testing for all my high-risk patients, as well as metastatic, castrate-sensitive, castrate-resistant, if it hasn't been done yet. Sometimes we don't have, it's not easy to get the tissue because it was the initial prostate biopsy or prostatectomy was done years ago, or the tissue is not good enough for NGS testing anymore. So, you don't want to not be able to identify that patient with the BRCA1, BRCA2, PALB2, these important mutations. So sending the germline testing is just another way to kind of cover your basis and pick up all the genetics that we can potentially target with our treatments.